all these lovely people so excited about our risk assessments and
Well,
audits.
well, aren't we sad individuals that we get excited about risk assessments? But we do. So
I think this is the creme de la creme of the people that want to get it
exactly,
right.
exactly. And then, of course, the thing about that is we are probably here preaching to the converted here. However, hopefully this will be useful to lots of people.
Absolutely. So, yeah, welcome everybody. It's lovely to see you. Our last in conversation for the compliance clinic of this year.
Yes.
So yeah, I think what we will look at doing next year is actually having some sort of have an all over update of anything that is current, but also have one particular topic that we will concentrate on as well, because I think that's quite useful, isn't it?
Yeah, I think so. I also think the you and me just sitting chatting about whatever's come up is really useful. So I think maybe do a bit of a combination of both, but it really depends what our lovely audience would like. Happy to do whatever works best for everyone.
Yeah, no, absolutely. And if anyone does have any hot topics that, or bugbears or things that niggle at them that they'd like us to concentrate on more, please do let us know. You can let us know in the chat. You can send an email to Sam, Adam, just let us know because we are here for you.
We are indeed. We are.
So, Pat, we are going to demystify.
We're going to demystify risk assessment. So I'm just going to share my screen, and I have got this for Adam. Here we go. Can you see that? I hope you can.
We can.
Good. Right. Okay, here we go. So as I say, I've tailored this especially for you guys. So I've cut out stuff I didn't think you'd be interested in, and hopefully you will like what I've put together. So we're calling it demystifying risk assessments because actually risk assessments still, I think, hold a certain mystique. And I think quite often we have this, oh yes, do a risk assessment. But then what about those who don't really understand what a risk assessment is or how to do it? So that's what we're going to look at today. So we're going to look at how to assess it and how to and how to act on your findings. I just would like to I've got the viewing panel across my screen, so I can't see everything that's written on my screen. So right, would you know how to do that, Lisa? Or Sam? So it's covering up my so our faces are covering up my application.
I think you might bear with.
Sorry about this, right? Hide self view, maybe that's it.
Yes, I think it's
No,
it's
that's not
about
it.
gallery
No.
view or
Now I've gone and you guys are still there. All right, sorry about this. I didn't try this out earlier. Right, never mind. We'll try and go just with doing it like this. But I know there's a way that you can.
Sam, maybe if you can have a little Google.
Sam, could you just, have a little think about how I can just put everybody, put you and me and all participants across the top of my screen rather than just having you down sides there. It's even worse. Wait a minute. I wonder if I
switch to
there
right.
we go.
Oh yes.
I've now gone. from that. So that's good, a good thing. This is what we're going to look at: risk, how to assess it, and what to do with your findings, and then as employers, what your legal and statutory obligations are relating to risk, and then what risk assessments need to be undertaken. We're also going to look at the link between risk assessments and significant incidents. So let's look first of all at the legal stuff. So a risk assessment it's not just something dreamt up by the CQC. It is a legal requirement for all employers and the self-employed. And the legal bit is that if in your practice you have more than 5 employees, then you must record any significant findings. This is a health and safety law, part of the Health and Safety at Work Act. And it is good practice to record your findings even if you have less than 5 employees. So let's first of all just consider what it is we're talking about with risk, because sometimes risk is confused with something else that we come across, which is hazard. So a hazard is something that can cause harm, and then the risk is the chance of harm being done. So in those little pictures there, you've got the sharks swimming in the water there. That is the hazard, because it could cause harm. And then what is the likelihood the shark's going to come and bite your arm or your head off? Well, I would say pretty high. So that's the difference between a hazard and a risk, which is really important for when you do a risk assessment. If we wanted to put it in really simple terms, all a risk assessment really is just taking a long look at what could cause harm in the workplace, and then looking at what you currently do and what you may need to do in addition to reduce the risks associated with the hazard. So the hazard here is that the lorry is going to topple over. So just doing a risk assessment in itself isn't going to do anything. You have to implement some measures to prevent that hazard turning into a big something that causes a major risk. And in simple terms, often the best person to do a general practice risk assessment in your practice is, obviously would need training to do this, is the newest member of your team. Because what happens when we work in a practice for a long time is we go blind to some of the things that are there in practice that could cause harm. So, for example, I went to a practice once many years ago, and I saw an open bottle of bleach on top of the loo. And then I said to the principal, how come there's a bottle of bleach in the loo for any and everybody to really cause all kinds of problems with? And he had no idea what I was talking about, even though he'd been into the loo many times, because after a while we just go blind to it. So I think that's an important thing to remember. A little bit of a reality check now. So we can minimize the risk of something going horribly wrong, and we can manage risks, but it is never possible to eliminate risk altogether. So risk management is about reducing risks as far as we are able and not doing this. Presumably this gentleman here has done a risk assessment, decided it's not windy today. Otherwise, I think there's a real risk that he will be blown off his sky-high platform. Even just looking at that picture makes me feel queasy. And then I think we also do need to remember that no matter how good we are at our risk assessments and our risk management, mistakes do happen. And they happen for a number of reasons. That could be lack of knowledge, skill, experience, becoming distracted, tiredness, ill health, trying to do too many things at once, something I'm incredibly guilty of, systems or procedural failure, and then sometimes things just go wrong. With the best will in the world, you've put everything in place, you've done all your risk assessments, you've managed all your risks, you've done all your audits, you've looked at all your significant incidents, that doesn't mean that things are never going to go wrong. Things will go wrong just because they do. And so let's think now about what the CQC's expectations are. Well, they expect us in practice to be aware of what the risks are, to manage those risks to reduce a recurrence of issues, to record evidence you've done it, and to review your processes regularly to ensure that risks are kept as low as possible. Now, I'm sure you will all be aware that the CQC has moved away from the CLOEs, the key lines of inquiry, and now has quality statements. Now, throughout the quality statements, and there are 34 of them, there is this focus on continuous improvement. In particular, the things that allow you to create evidence of and real living proof that you are continually improvement are feedback, audit, and risk assessments. Now, we're not going to talk about feedback or audit in particular, but we are going to talk about risk assessments. And so risk assessments are really important and all very well. You must, though, have evidence that actions that are arisen from your risk assessment have been acted on. Otherwise, it's just a waste of time. Now, one of the things we do at Dentistry Compliance is we go into practices. We're very privileged to do so. I know Lisa does as well in a different context. Our team goes into practices and does mock CQC inspections and compliance audits. And one of the things we often find, and this is reflected on the CQC website as well in reports on practice compliance, is that we find incomplete, absent, or out of date risk assessments. And in particular, we find fire, health and safety, so things like electrical safety, a general practice risk assessment, and COSH are very often out of date. Not only are they out of date, they're often misunderstood as well. So let's just have a little think about understanding what risk is. So the dictionary definition of risk is chance or possibility of danger, loss, injury, or other adverse consequences. Well, this gentleman here is going to suffer adverse consequences because he has not considered that if he soars through that branch, he's going to go crashing to the ground. Now, I actually prefer to define it as the problem you don't know you've got yet. So if we all knew what problems we were going to have, then we would all take measures to avoid them and deal with them. But I think we don't. So this particular gentleman here, he also seems to be wearing heels, which is a bit bizarre, standing on a branch of a tree. But I think that really, for me, really sums it up very, very well. So risk is the problem you don't know you've got yet. So your risk assessment should identify what the risks are, what you currently do, what you need to do, if anything, to reduce risk further. And risk management is how you then ensure that these risks that you've identified are reduced. And you can't just talk about risk assessment in isolation. You have to talk about risk assessment and risk management together. Let's think about how you might do that. So, as I mentioned, you're going to identify the hazard. That is the potential for the thing to cause harm. So the shark in the water, huge potential for the shark in the water to cause harm. And you can then use a template. I particularly like this one, actually, to decide on the level of risk the shark presents to you. And that will then help guide your action plan as to what you do with the results of your risk assessment. So you'll see down on the left-hand side there, you can see that the word likelihood is written there. And then across the top, the word severity is written. Now, likelihood means what is the likelihood that things will go wrong? Go back to the shark. I would think it's very high. Frequently is likely to be very high if they are sharks that particularly like to take a chunk out of you. So that's the likelihood. What is the severity? Well, I think that's for you to assess, but it could be slight, serious, or major. Now, if it's slight, you might say that that's low risk of severity. If it's serious, medium risk of severity. Major, it's high risk of severity. And the same for the column on the left. So is it, if it's seldom, that there's likely to be a problem, then it's low risk, lower risk. If it's occasionally, it's medium risk, and it's frequently, it's high risk. And you then can put these letters onto the grid, or you can measure it quantitatively. So this is you measuring it qualitatively, and that will then guide you. Now, let me just show you our dentistry compliance. This is our risk assessment template. So on the left, you can see there is hazard. So that's the task or the activity with the potential to cause harm, shark in the water. What type of injury might result if harm occurs? Death. Who may be affected by this in the practice? Obviously, you won't be having sharks in the practice, but let's make it a realistic dental example. Let's say you've got a dental nurse who refuses to wear protective glasses. So that is the activity with the potential to cause harm. What's the type of injury that could result if harm occurs? He or she could lose an eye, could be blinded. Who could be affected? Definitely the dental nurse and anyone else not wearing glasses. What are the likelihood of injury occurring with the current controls in place? So bearing in mind the dental nurse is not wearing protective glasses. So the likelihood of harm occurring is high. What is the likely severity of the harm if injury does occur with the current controls in place? Again, I would say that's high. And you then can assess your risk level as low, medium, or high. So if we go back to the previous slide, you've got high likelihood and the type of injury could be severe, is likely to be severe. So that puts you in the bottom right-hand corner of risk, which is high. So you then put the current control measures you have in place. Well, in this case, there aren't any. And then list further control measures that are required. The dental nurse needs to understand that he or she must wear protective glasses. Who's going to take responsibility for that being implemented? And then what is the date that you're going to review that? And that is how you do all risk assessments, depending on what it is. It's how you do COSH risk assessments. It's how you do a general practice risk assessment. It's how you do your health and safety risk assessment. All of those things will fit very nicely onto this template. We also used this template extensively during COVID to identify the risks and the control measures required. So, we provide a pre-populated version of this for practices to tailor to their practice. You don't need to do that. You can create your own. So then you now know what level of risk you've got. So if it is low risk and you decide that it's acceptable, so on a numerical basis, you've got a risk level of 2. And so no further preventive action is necessary, but some consideration should be given to cost-effective solutions, as in give the dental nurse a pair of protective glasses and ensure he or she wears them. You should monitor the solutions to ensure that the controls are maintained, and so on, up to intolerable. So you would then need to decide in your practice whether that is an intolerable risk, the dental nurse not wearing protective glasses. Personally, I would say it is. And if it is a patient, that is also an intolerable risk. So activity shouldn't be started or continue until the risk level has been reduced. So I hope that demystifies it a little bit. So what guidance could I give you? Well, I would suggest that you review all of your risk assessments, make sure that they're carried out at appropriate intervals. That is for you to decide how frequently it should be. Now, if you have, let's say you're doing a general practice risk assessment and you make some major changes to the practice or you bring new equipment in, then you would be well advised to do a risk assessment both before and after the changes are made. So it's no good just to say we'll do all risk assessments annually, because it must be tailored to your specific practicing circumstances. And decide who's going to take responsibility. Very often it's the practice manager that takes responsibility. And then again, in red there, because it's so important, make sure all the actions arising from doing this risk assessment have been acted on. And I'm going to stress yet again, never ever do risk assessments as a pointless tick box exercise. So you just take a template and you just tick to say you do everything. Personally, I think that's a waste of time, money, and if you do it on paper, a waste of paper as well. So make your risk assessments count. And I now just want to have a little look, bring in the importance of significant incidents. And in particular here, I mean significant adverse incidents. So what do we find when we go into practices to do our mock CQC inspections? And what does the CQC find? Well, very often a very poor understanding of significant incidents and in particular adverse incidents. And then or there might be an understanding, but they haven't been recorded, and there's no evidence that learnings that have come out of it, so something goes wrong in the practice, and there's no evidence that anything's been done to stop it happening again. So let's just pause for a moment, and like we did with risk and hazard, and look at what significant incidents actually are. I think a lot of people think they are only negative things. They're not. They are also positive things. So a significant event is something, might be stating the obvious here, but it is something that is significant. So it either has the potential to be good or the potential to be adverse and cause a problem. Now, analysis of significant adverse events should examine what went wrong or right rather than who caused the problem. If you turn it into a blame culture, oh, well, such and such, Lisa didn't do this, naughty Lisa, then I think you are less likely to be relying on Lisa to be honest about what things have gone wrong in the future. So always when you're doing analysis of anything that goes significantly well or significantly badly, look at what happened, not who is responsible. And the reason for talking about significant incidents is that there is a link between risk, audit, and significant incidents. Let's look at what that looks like. So how are they all linked? So risk assessments identify the risks with the current controls in place. We've talked about that already. Risk management manages the risks that you've identified to reduce the risk where required. Audit then measures the effectiveness of your risk management processes. So let's say you've done a health and safety risk assessment, you identified things that need to change, and then you decide you're going to do, and let's say you identify a breach in your infection control procedures. When you do your infection control audit, then that should identify how successful or otherwise you've been at implementing your risk management processes. I hope that makes sense to you. So how are they all linked to significant incidents? Well, ineffective risk management means you are more likely to have significant adverse events. So if you are not good at your risk management, you are more likely to have things go wrong. If you are effective with your risk management, so that's your risk assessment and then managing your risks, then you are less likely to have significant adverse incidents. So And if they're really, really effective, then you're more likely to have more positive significant incidents. So that's things like patients paying you compliments, giving you great reviews, great practice reviews, patients writing you nice letters, that sort of thing. Well, that's all very well, I can hear you say. Why do we bother with all of this? Well, I can tell you the number one reason we bother with it is not because it's what the CQC is expecting. The number one reason is what Albert Einstein didn't say, although it's widely attributed to him, which is the definition of insanity is doing the same thing over and over again and expecting a different result. So let's say you've done your risk assessment, but you haven't put anything into place. So you haven't managed the risks, you haven't changed anything to make sure that whatever it is that's gone wrong doesn't happen again. Then guess what? It's going to keep happening. And that's a real problem, because when we talk about significant adverse incidents, we're talking about all kinds of things like lab work not being delivered, people running behind the whole time, the practice is not working efficiently. So it is in your interest as a practice to make sure all this stuff is done, not because the regulator says you need to do it. So how should you record significant events? Well, we suggest you use a template and that you review them at meetings. And what you're trying to do is prevent the recurrence of adverse incidents and encourage the recurrence of positive events. And then if you use a rating system, you can then decide if there was from your significant event no negative outcome, or possibly a positive outcome, or a mild negative outcome, moderate, serious, or a severe negative outcome. Now, an example of a severe negative outcome would be the patient having been prescribed or given, or both, the wrong antibiotic and leading to anaphylactic shock. That would count as a severe negative outcome. And then the other things are graded accordingly. What could that look like? Well, you don't need anything complicated. You just need a description of the event. So what happened? How serious was it? What was the level of seriousness from that table I showed you there? What was the level of seriousness? Was it a clinical event or a non-clinical event? Who was involved? What steps have you taken to avoid a recurrence? Or if it was good, a good significant event, what steps have you taken to encourage recurrence? And then what you've learned from the whole thing, and your name and the date. So just something very simple like that to record your significant events on. Now, CQC loves this, really will be very impressed with this, but that's not the reason to do it. The reason to do it is because it will lead to fewer adverse incidents and more positive incidents. So let's think about risk management and what major incidents you could experience. Now, this list is not exhaustive by any means, but these are all the things that could go wrong, major, massive things. And I think I can pretty much say I have come across trying to help practices in all of these circumstances, and I bet you Lisa has too. So PC hard disk failure, system hacked, that's thankfully not that common, but with cybercrime increasing all the time, then I think we can expect that to happen. And all of these things should be on your risk assessment. Flood, fire, power cut, compressor failure, burglary. And then what you need to do is to risk assess to minimize the consequences and decide on risk management strategies for each of those things. So, and actually it can be a really good team building exercise to do it together. Don't just leave it to the practice manager to you guys to do it. Just think about it as a practice team, and it gets everyone then involved in thinking about it. So what risk assessments should we do? Well, bear in mind that all non-compliance carries some kind of risk. So think about what can cause harm in a dental practice. And again, this is not an exhaustive list, but you'll have health and safety risks. So that's things like slips and trips and ladders and lifting heavy items. You've got hazardous substances. So that's COSH. There's a massive amount of misunderstanding about what COSH risk assessments should be. Just bear in mind that COSH stands for Control of Substances Hazardous to Health. So that doesn't mean you need to do a COSH assessment, risk assessment for every item you have in your practice. So you don't need a COSH risk assessment for washing up liquid. You should have material safety data sheets, but you only need to do a COSH risk assessment for things that are hazardous. And you identify hazardous things from the label, and they'll have one of the icons that show that a substance is hazardous. So something like a skull and crossbones or fire, that sort of thing. Infectious organisms, obviously, we spend a huge amount of our time in dentistry trying to make sure that infectious organisms don't cause a problem and we don't transmit infection from a patient to staff to other patients. And that's what a lot of our time is taken up with in dentistry. Legionella presents its own specific risks and own specific hazards. Then you've got hazardous waste, you've got amalgam, you've got ionizing radiation, you've got autoclaves and compressors that could explode. You've got anesthetic agents. You've got medicines. You've got display screen equipment. So all of those things have the potential to cause harm. So you might say, well, how can a display screen equipment cause harm? Poor posture, which I have, when using display screen equipment, and then tired eyes, that sort of thing. I think so. All of these things have the potential to cause harm. Also included electrical equipment, ergonomic factors, so that is people sitting in the wrong position, fire, first aid, manual handling, I've mentioned that already, poor ventilation, often completely overlooked, sharps, work equipment, working environment, slips and falls, stress is another thing that has the potential to cause harm, and a poor workplace culture. So it's not just limited to things like equipment that could blow up or break, or X-ray arms that could fall off the wall. There is a lot of stuff we have in practice that could cause harm. And with a risk assessment, what you're looking at is what is the potential for harm, what measures do we have in place to make sure, try and keep the risk of harm as low as possible, and what, if anything, do we need to do in addition. Let's take sharps, for example. If you have an open sharps bin on the floor, what are the chances of harm? Pretty high. What if somebody kicks it over? You've got sharps all over the floor. What if there's a child in the surgery? So it's the problem you don't know you've got yet. So you're sitting there quite calmly with your sharps box open at toddler height on the floor. It gets kicked over, and sometimes all of a sudden you've got a massive problem on your hands. All of those things can cause harm. The other thing you need to do with a risk assessment is you need to consider what groups of people might be especially at risk, and then think about if you need to bring additional measures or special measures in to reduce risk even further. So during the pandemic, I think we became really good at that, thinking about, well, such and such a person is pregnant or has specific health issues that might make them more vulnerable to infection with COVID. Therefore, what additional measures do we need to put in place to reduce the risk even further? An example of these people who might be, groups of people that might be especially at risk, are lone workers. So that could be a hygienist. Hygienist is quite often doesn't have a nurse. I know the GDC says they should, but I think everyone knows that it's not a universal thing. or somebody who is seeing a patient in an emergency. Are they a lone worker? Have they gone in on their own? And if they have, then what measures have you put in place to protect them? Pregnant and nursing mothers always need to be considered, children, young people, and vulnerable adults, and disabled team members. So just have a little think when you're doing your risk assessment, who could be especially at risk? And this is, again, this won't be an exhaustive list. There will be others that should be on the list. And then while we're on the subject of risk, you might think it's veering off the subject slightly. I don't think that. Let's think what else poses a risk to the practice, which is important, or the dentist or dentists. And therefore, if it is a risk, what precautions should we take to reduce or minimize risk? Well, I'll give you a clue. It's this gentleman here with a vulture behind him. So risk to clinicians and the practice. So the potential for litigation or GDC referral, that would be poor or inadequate patient records and lack of valid consent. And in fact, lack of understanding of what valid consent is. So personally, I think that is a risk and with the potential to cause harm to the practice and the GDC registrants. What else? What other risks are there? Potential breaches of confidentiality, potential breaches of data protection and GDPR. All of those things need to be taken into account. Poor communication with patients and team members. Very, very easy to get communication wrong, as they have clearly done in this picture here on the right. And clear communication, I think we all know, is very important. And communication is something that can always be improved, however good it is. And then poorly handled complaints. So I think, and this again, this is linked to your risk assessments as well. So people are likely to complain if risks are not managed effectively. So those things I think do need to be considered as well. And then just to finish, last slide, you know, I think I don't think it would be right that we think, oh well, you know, you can get rid of all risk, and sometimes taking a risk is a positive thing to do, but there is this fine line between taking a calculated risk and then looking at blowing your finger off with a shotgun. And I'd be pretty sure that when Lando Norris won the Grand Prix, won the F1 title yesterday, he didn't have a cameraman sitting on his bonnet like that, because I would suggest that might be an unacceptable risk. So that's just a whistle-stop tour through risk and demystifying risks. I hope that's helpful. I hope that makes sense. I'm really happy to take any questions from anyone. We've got 20 minutes left.
Thanks, Pat. We've had Pamela has said, can we share an example of a positive event? She can't think of any. It does feel like that sometimes, doesn't it? But this is, I don't know about you, but I was thinking about this when we were talking, Pat, and it's about the stopping things from happening. Rather than it be a, yay, look at this, it's positive. It's kind of your safety net, I suppose, is the right way
Yes.
to put it. So like our risk assessment on anything to do sort of disability and accessibility to the practice and things, for me, that's a positive thing because it means we can have more patients and be inclusive. But it's difficult to look at the positives when we're actually almost feel like we're going looking for the bad stuff.
Yeah, no,
Sometimes, don't
I
we?
agree, Lisa. I think positive events are patients that say to the nurse, or perhaps on the way out to reception, goodness me, that was a really good visit, and I was so scared when I came in, and now I'm not. That is such a great positive event, positive yeah, and it's significant. So I think capturing positive things is really important, and it's not just looking at things that could go horribly wrong. It's things that have gone well. The patient that comes in and says, "Well, you've changed my life," because I had no confidence before, and now you've done this wonderful whitening or whatever it is you've done, and I feel I can smile on photographs again. So I think just capturing things, making sure you capture all feedback, and that I didn't talk about feedback today, but it's capturing feedback, I think, and in particular positive feedback,
Yeah.
is really helpful.
I think in a lot of this as well with our risk assessments, it's not about being able to stop it completely. It's just about us being prepared, and making sure our team are prepared. So for anything like the fire risks, health and safety risks, all those kind of things, medical emergency training, what are our risks?
Yeah,
And they'll never be gone,
absolutely.
will they? Because we're dealing with the public here and we're dealing with people, and in our environment of healthcare, there's lots that can go wrong, aren't there? But it's about making sure our team, we did our ILS quite recently, and
Yeah,
one of our those Jilly's tucked away in the office today, but one of the things Jilly's very keen on is it's okay, we do ILS, we do pills because we do kids sedation, and it was great. We paid, thousands of pounds to get 40 odd people sorted, trained, but that's kind of wasn't enough because now Jilly's asking them for feedback of do they feel prepared in that situation now? Because we can't just do the course and assume they know.
you
So
can't. That's
the
really
risk
important.
assessment, yeah,
That's really important, Lisa. And so then the next step needs to be, um, okay, so we've done the course. What can we do to reduce the risks even further of getting it right when somebody drops down dead in front of you? What I would recommend then is that you do emergency scenario training every quarter, I would suggest, and you do it against the clock. So obviously, we all know that you've got 3 minutes to make a difference. And so you do it as a team exercise. I mean, you've got a huge team, Lisa, so doing it for 40 people, I should think, is a little bit or a lot of a challenge. But I think, those with smaller numbers in the practice do emergency scenario practice. Same with safeguarding. Practice what you would say if a patient comes in and says, "I've been beaten." Because when you are confronted with it, there will be some people who will react instantly and remember everything. There will be a lot of people who think, "Oh God, what did they say? Is it air breathing? Yeah, does it go, or does it go breathing airway?" So there will be a lot of people who will not feel prepared because all they've done is listen, albeit practice as well. But you have to keep reinforcing it, I think, for it to stick.
and check the understanding, isn't it?
Yes,
We
yeah,
had an incident a few years ago where unfortunately a gentleman, as he was walking into the building, um, ended up sort of heading towards the door, but then falling backwards. Um, Now we acted really appropriately. We got him in. His wife was with him. His wife was screaming that the door had hit him, and that's what made him fall. Um, and we got him in the building. We'd got lots of clinicians around, but we also at the side of it, we were taking statements, recording what we were doing. The wife didn't want him to go to the hospital because he'd only just come out the day before. There was lots of quite critical things,
yeah,
in that moment. And I was really proud of the team of how they acted, how they, well, reacted to it and what they did. Um,
yeah,
but also at the same time, when I get the phone call to say a gentleman's fallen and he's gone in hospital, and really sadly he ended up dying a few days later, but not particularly related to the actual fall.
yeah,
And whilst I was deeply saddened by it, I also felt quite calm, whereas
yeah,
I think some would panic. because I
definitely.
know what we do and the risk assessments that we've got and everything that we have. We get a disability audit once a year. I know we don't have to. We quite like to do it because
Yeah.
it prepares us for things that could happen. And, you know, that could have been a really, really messy situation. But the fact that the staff were prepared, the team were prepared, they knew what to do in that medical emergency. Um, we did we got somebody out to test the door. Has there been any faults on the electric door?
Yeah.
None of that. And it was just, it is, some situations are horrible, but I think for me, it's, you know, we said about, like Pamela said before, about positive outcomes. Whilst it was a sad situation, a positive outcome is that we did everything we could to
Yes,
reduce that risk.
absolutely. Yeah, yeah.
Would you mind, Pat, if we just have a few minutes on about I know it's a HR thing and we don't want to delve too deep into employment law, but risk assessments when it comes to HR and our team. Um, I know I get asked this quite a bit, you know, about
Do you? That's
pregnancy.
interesting.
Yeah, pregnancy, people that have illnesses that need adjustments making. Um, Now, for me, it's always about let's get occupational health involved. Let's see if we can make adjustments. Are there any more? What are your thoughts on those risk assessments?
I think that's a really good question, Lisa, and I think it is what I said on the presentation, which is thinking about all the people that could be affected more adversely than people who are in good health or you know, it's about thinking, so what groups of people might especially be at risk here? And you know, it's the lone workers, you know, a lot of risk attached to lone workers. Obviously it's pregnancy, it's people in poor health, people with weak immune systems, people on chemotherapy, people on with uh, and many adverse medical histories going on. So it's thinking about all of them and thinking, have we either made accommodation for all of them within our current risk assessment, or do we need an additional risk assessment that says, okay, what should we do for a lone worker? Now, I think you need an additional risk assessment for a lone worker because the risks are very specific. I think you need a specific risk assessment for people who are pregnant, a specific risk assessment if people are medically compromised, immunocompromised. So I think it's thinking through everything to make sure that you're covered on all bases, because the general risk assessments may not necessarily take into account or people with particular disabilities. May not take all of that into account. So I think it's going further with everything and saying, are the people who are more at risk? Somebody who is who's got poor sight, you know, have you thought about people with poor sight in your general risk assessment? And if you haven't, then do you need to? And do you need to put additional measures in place for people who don't see as well as they should? So I think it's a massive subject, and I think it's very, very poorly understood.
I think you're right. Yeah, I mean, from a doing the right thing for your team and your people and your patients it is it should be done. But then you also are looking onto the employment law side of things as well, aren't you?
Yeah, yeah, yeah.
There's legal obligations there.
Yes, yeah, but there are legal obligations just with all with health and safety risk assessments as well. So you must do a risk assessment and record the results if you have more than 5 employees. So that's not employment law. That's health and safety at work
Mm.
law. And then in terms of employment law, then I think things like making sure, but this is more of an audit really than a risk assessment, making sure that you've got all the right documents for everybody, you know, has everybody zero converted? Have you got evidence of that? And if they haven't, then what have you done about it? so that you make sure that you've got all the correct documentation. Have we got references for everyone? And if we haven't got references, do we need to get some? And if somebody's been in a practice for a long time and you haven't got references, then do you need a character reference? And I think it's looking at the list, and this is where the CQC is helpful actually, because there is a list of required HR documents that you have to have for every team member. And if you don't have that, then and I guess the CQC has the list, but I think the more important message is that there's a reason for everything being on the list. So things like DBS disclosures, Hep B references, making sure that you've got a CV that has exact dates in it of where people have worked, and if there are periods that are unexplained in a CV, that you understand what that person was doing at that time.
Yeah. So the DBS is oh, that's got feedback. Oh, sorry, guys. Yeah, DBS. I mean, we've had things come back on people's DBS. Been nearly 30 years now. We've seen quite a range. We risk assessed and decided, what is the risk.
Yes.
But I mean, I think that's pretty straightforward. But then I know that some practice managers worry about the medical history side of things for the team.
Yeah.
We're almost afraid to ask for a medical history for a new team member, because if something's on it and then we've risked this, it gets very.
It's very difficult indeed.
Yeah.
I think when you're doing something like a medical a medical history, it's has the person got something either physical or mental in their medical history that impacts or could impact their ability to do the job. And if the answer to that is yes, then have you put enough measures in place to protect them? To which the answer is yes or no. And so I think that it's, and also with DBS you mentioned, somebody's has an offence that has no relation to their ability to do the job. Is that relevant? No, it isn't. You need to know about it, yes, but it doesn't need to stop you taking them on.
Yeah, I think interesting. I've been asked by quite a few practice managers over the years when things have appeared on DBSs, and also along the lines of something's happened since they've been in your employment that now means that if you were to do another DBS, something would show up. Now, for
Yeah,
me, it's not about particularly what they've done; it's about the honesty or the dishonesty.
yeah,
Now, that's more of a risk to me than if someone
yeah,
was a little bit silly when they were 18 on a night
yeah,
out.
yeah, absolutely, yeah,
But if they're not honest about things,
yeah,
that's me. That's me,
yeah, yeah,
my risk.
yeah, yeah.
We've got a good question from Julia, if that's okay, Pat. And what would you
Yes.
do about CVs, references for people who've been at the practice since, say, 1985, and the practice changed hands since? Would you be expected to have that kind of thing?
Well, the answer isn't as clear as perhaps we would like it to be. And if you're doing that from if you're looking at this from a regulatory perspective, as what will the CQC expect, then it's very much dependent on what your CQC inspector is interested in. And I would like to say they're all consistent, but they're not. And so you could get a CQC inspector that they will almost always ask about all the personnel records. And then you will get some that will say, yes, we understand they've been in the practice since 1985, and we don't have all those records. I think if you want to take let's call it a belt and braces approach, then I think having a CV for everyone is a good plan, and it only has to be employed at the practice between this time and this time, or whatever practice, and the exact date. Now, the reason they focus on that is because they want to know if there were any gaps in where somebody was employed. So they want to know that say you were employed from the 9th of September 1985 to the 8th of December 2025, and that there have been no gaps in your employment. Now we did have, I have experienced a situation where somebody had actually had done something that really wasn't good and had missed this off their CV. And then if it's sort of 5 years after the event, then it kind of falls off. But I think I would have liked to have known what had gone wrong, or what this person had done. So in terms of should you get these things, I think that again, belt and braces approach, that you should get a character reference for everyone, so that you do have references for everyone, if you can, and that you do, if possible, have a CV. It doesn't need to be detailed. It just says between this date and this date, I did this, because the CQC's argument is that person could have been in prison.
Mm. Yeah, no, it's good. That's a really good answer. Thank you, Pat. Wow, we've come up to the hour almost.
Didn't that go quickly? Goodness
You were
me, sorry,
great.
I faffed
No,
about a bit at the beginning, but
no. That was fantastic. It was really great. I think we can drive ourselves a little bit nuts with the risk assessment
yes,
sometimes. And
I
what you've done
agree.
there is actually, just give us that reminder of we don't need to drive ourselves nuts. It's quite a basic thing, really, that could have a really, significant effect on the practice.
Yeah,
It's one of those almost unthankful tasks sometimes and I always think, well, doing it and finding that you're doing okay and everything's fine is actually enough thanks in itself. At least we've done it. At least we're not finding stuff all the time.
exactly. No, exactly. I think apply that definition, my definition, Pat's definition, which is it's the problem you don't know you've got yet. And I
Yeah.
think that is really helpful, because all you're doing is looking for things that could go wrong that you haven't thought of.
Yeah.
But in order to stop driving yourself mad, there are some things that are really unlikely to happen. So do you need a risk assessment? I don't know. Actually, we've had a couple of incidents in the village where our practice is, and it's quite an elderly population, and a couple of and it's on our practice is on the high street, and a couple of the shops have had somebody drive through the front. The dry cleaners, for example, had somebody from the village drive straight through the front of their dry cleaning business, and I think they ended up about 2 foot away from the person, that the receptionist. So would you think of that? I'm not sure I would, to be honest. But what they've done now is put railings at the front so it can't happen. Now, this isn't a dental practice situation, but it's kind of, it is thinking about what is the problem that I don't know I've got yet. And that is all it is, really.
I think that's the thing. I mean, as you know, and as you do, I go into practices and do team
Yeah,
training on complaint management and prevention and all of those.
yeah,
And the one thing that I would always encourage, if you've got a complaint or even a review and it's the same couple of things that keep coming
yes,
back and back,
definitely.
actually go back to it. What's the risk assessment of us, having a negative outcome on something? It might be that the dentist had the back to the patient and the patient felt not listened to.
Yeah,
It could,
exactly.
what's the risk of a patient feeling like that? And for me, it's actually enables you to have the conversations particularly with the team sometimes to
Definitely.
to prevent those things. And
Definitely.
I love a juicy complaint. I love complaint management. But if I can prevent them, It's much
Definitely.
better.
Definitely. And I think, that's why I put in complaints and poor patient records as being a risk, because it's a risk to the
Yeah,
practice. It
yeah,
really, really is. Not only that, it's a risk to the individual GDC registrant as well. So
massive.
I think, and I'm a big fan of complaints trackers and then analyzing complaints trackers for trends and saying, well,
Yeah,
actually, this has now happened 4 times. Why has that happened 4 times? What do we need to do to stop it happening a fifth time?
yeah.
And proving to ourselves that the definition of insanity is doing the same thing again and expecting a different result.
Exactly, exactly. And on that happy note, Pat, thank you so, so much.
Pleasure.
I do appreciate your support. Again, anybody that would like to have a dentistry compliance demo, definitely urge you to do that. As always, if you think of anything or want to ask anything specific to myself or Pat, please do get in touch. We're more than happy to listen and help if we can. So yeah, last one of 25.
I know. Thank you, Lisa. Just to say, actually, I didn't put a QR code on the end of that presentation deliberately, but I think in future I may just put one on so that people can click through and get a no obligation demo if they'd like to, because you're always kind enough to recommend us. So
Oh,
I'll
no,
do that.
it's fine. Thank you, everyone that's joined us live, and thank you to everyone that's taken the time to listen to us recorded. So, thank you so much, everybody. Have the best Christmas. Have a break.
Yes, because
Enjoy.
being overtired and overwrought and burnt out is a
That's a
risk.
risk, especially with us practice managers. Risk assess
Absolutely.
ourselves and
Yeah.
prescribe a nice break with peace and
Yeah.
quiet
Yeah.
and just doing what you want to do.
Absolutely.
Oh, thank you guys. Take
Yeah.
care and have a good
Yeah.
day.
Thank you, audience. Thanks very much, and have a very good Christmas, everybody. And see you
Take
in the new
care.
year.
See you next year.
Thanks. Thanks. Bye.